So yeah, tonight is all about innovations in football injury management, followed by an expert panel roundtable debate. And I thank you all for joining us. We got about 150 people signed up for this from UK, Ireland, USA, France, Spain, Italy, and Germany. And a kind of good balance of physios, sports medicine professionals, clinic owners, strength and conditioning coaches, and some university undergraduates. So quite a lot of people. I'm just checking the door, making sure. So my name's Paul Donnelly. I'm the UK Managing Director for WINBACK Medical. And the reason I put this shirt up here is that although we work a lot in elite sport, we also work at grassroots level. And our local team whose shirt we sponsor are in the FA Vaz final on Saturday. So we're all off to Wembley. So the whole village is pretty pumped up and excited about that. Tonight's agenda is really in two parts. We're going to be looking at an area which is a very, very kind of common footballing injury, and that's all to do with the groin. It's about pubalgia, and it's about how to integrate technology and movement in rehab. So I'll introduce the speakers in a second. So Q&A on that session, if you could use the chat function within the Zoom piece there, just get your questions coming through as things come in, and then we'll Q&A at the end of that. And then we'll move into this roundtable discussion that we've teed up tonight. Again, I'll introduce the speakers, but what we're really interested in is how has this pandemic affected pro football physio practices? You know, what's happened to injury rates? What kind of injuries are people seeing that might have been unusual given the changes that people have had to go through in training practices and recovery practices? So we're going to be asking the panel to share their views on, you know, just what's happening on injury rates. We'll look at, again, training and recovery, what's happening and what's happened in that area, how it's affected, or how it's been affected by training in the sort of the bio bubbles that people have been working, and what are the challenges have been. And then something I don't think we talk probably enough about is how have people's mental health effectively been impacted. So, you know, lockdown 1 was pretty seismic for everybody, and then we came out of it into lockdown 2. Things started to get back to a little bit of normality, and then boom, we had lockdown 3. So interested in how, you know, people's view and the panel's view on how they've coped with that in terms of mental health, not just the players, but the team, the coaches, and the staff. I think that's quite an interesting topic. And then from a technology point of view, what technologies have really been seen to help out? You know, we believe that what we do has helped, and we'll discuss some of that tonight. And then importantly, as a kind of takeaway for the new season, what lessons have we learned? Okay, so let me introduce the speakers tonight. So our first speaker is Ignazi De La Rosa, who's the lead physio with Real Betis, but has also worked with some of the Spanish players at Dortmund, and has worked in Barca football as well. So a lot of experience in the professional footballing environment. He's also, even as a youngster compared to me, he's a clinic director of his own practice in Barcelona called Sport Pro, and was the physio for, I think, 3.5, 4 years for Garbin Muguruza, who was one of the LTA, it was LTA #1 ranked in the world, and a former Wimbledon champion. So Ignazi's got a lot of experience with WINBACK technology and is one of our international trainers. So welcome to Ignazi. The second panelist, I'm sure is known to many of you. I apologize for the picture. It was the only one that we could get of you, and it's on your LinkedIn profile if you want to change it. But Pete is head physio at GC Performance at St. George's Park, and we have a kind of educational relationship with Pete and the team there. And as you know, St. George's Park is the contract for looking after the FA players is held by GC Performance. SGP. And Pete's bio, if I get this right, Pete was head of medical services at Widnes Vikings, working with Harrison Ross in Manchester, previously England Rugby League, Liverpool Football Club, and was also, I think he started the career at Bolton. So a long career in professional sport, and one of the key panelists tonight. Dan Kett, who's a senior physio at GC Performance also at St George's Park, and previously at Spire Healthcare, so has a great kind of combination of MSK, post-op surgical, as well as sports, football sort of physiotherapy experience, and was previously at Mansfield Town Football Club, and before that at IPRS. So Dan, you're very welcome. Next panelist is someone probably doesn't need any introduction, Steve Kemp. A bit like Davey, who will introduce next, got a big, I guess 6-7 weeks ahead of him as England head team physio, but was also the head physio and the sort of liaison between the FA and St George's Park, and really looking after the 24 England team. So massive experience in professional football, previously at Wolves, and still a senior lecturer at the University of Birmingham. So that's Steve, and you're very welcome, Steve. And last but by no means least, I've said David Henderson. Is it Davey Henderson more than David? Or you don't?
Doesn't matter. It can be called anything. I'm not easy.
That's great. So David's joining us again, as we were joking about earlier. Great to see Scotland in the final stages of a big championship, and you know, a lot of exciting games ahead, a lot of challenges. But David's lead team physio in Scotland, currently Motherwell Football Club, but again, a lot of experience, Sheffield Wednesday, Rangers, and Newcastle United. So that's the panel. And you may be wondering who we are. So I thought if you indulge me just for 2 to 3 more minutes, I could give you a little bit of background on WINBACK. We founded this company, or the company was founded in 2013 in the south of France, in Nice. And it was founded by a group of people who were working around Ptechotherapy, which is going to be the subject of the first presentation tonight. So Ptechotherapy is that combination of manual therapy, active recovery, and you know, a high frequency current, which is used quite extensively. But when we first came across it, it was a very passive modality, and we felt that we wanted to do 2 things. One, make it active so that it can be deployed through the acute, subacute, and chronic rehab phases, but also make it more affordable. So they were the 2 things that kind of got us started at WINBACK. We're in about 25 countries internationally now, 7,000 clinics and hospital, mainly orthopedic sports medicine hospitals. We kind of made our name in this professional sporting environment. So we probably have around 300 professional sports teams and associations that we work with. And that can be in multi-sporting environments. So everything from football to rugby league to athletics to triathlon to GB diving, for example. Triathlon, I think I mentioned, and also laterally into areas like Formula One. So we kind of think we have an understanding of the challenges that you have, you know, working in that environment. Hopefully we can add some value in that area. And then we kind of morphed out into 2 other areas. We have a business based in Asia, in Seoul, which services the kind of Far East and the US. We have colleagues joining us this evening, where we had our FDA approval back in 2017, and we work with groups like Hospital for Special Surgery in New York. We work with Johns Hopkins and a lot of the NFL, NBA, MLS teams. So again, that sort of relationship with professional sport has been ongoing. We started the UK company in 2017, so we came into the UK, and we've established about 120 centres. I would say 60% of those are within the clinic environment, and 40% would be in the sort of sporting environment. And then 12 UK training centres. So you may engage with us initially, but we do a lot of our kind of education in a peer-to-peer environment, where it's a physio or a sports scientist or an S&C professional talking to you peer-to-peer, because we think that's where things begin to come alive. Very quickly, just a snapshot of who we're working with. We've mentioned the home unions, some of the leading professional football teams are working with, key clinics that you see here, and then down at the bottom you'll see places like Flint House, which is the police rehab centre in Berkshire, and then Royal Berkshire Fire and Rescue Services, their rehab team works with us, and then also within the orthopedic area, as I mentioned before, UPMC, the Whitfield Hospital in Ireland. So a little touch of who we are and who we work with. And then two other things I wanted to mention is the educational relationships we have with the University of Northamptonshire. Brendan Skinner, who's the senior lecturer in that area, wanted to get technology or awareness of technology into the undergraduate program. So he's incorporated a lot of what we do into the undergraduate program. Whether people continue down that path or they don't is a personal decision, but then at least they have an awareness of what's being used in the private clinic and sports medicine environments. And then the second area, which we're very pleased to communicate, is our education partnership with people who have a lot of experience. So, Health Development Performance Network was set up by James Moore and Elizabeth Moore and Ken Joy, and they run, I would say, pretty high-level training events focused around the faculty that are extremely well known, and just a great partnership for us to be associated with. Finally, a couple of things in just summarizing. So what we're all about is removing pain, getting people out of pain, getting them into that restoration of function by loading and movement, leading up to healing their injuries faster. And our core technologies sit around Ptechotherapy, which is the focus of tonight, strength and conditioning, where we have a range of technologies around blood flow restriction in the smart cuffs, isoinertial flywheel technologies, which are getting a lot of kind of support and evidence base behind. And then what you see there in the middle, that G-Move suit, is kind of an active Normatec. So rather than having a passive recovery, we're using something that's active. That's the thinking behind that. And then within screening and assessment, WINBACK UK represents the Isoforce company for isokinetic assessment. And then we have our Fit to Go body screening, which is a clinic-based system whereby clients can come in, take a lifestyle questionnaire, and then come into the clinic for a full assessment. So that's a little bit about who we are and what we do. Final comments very quickly before we get into this. Thank you in advance for all your contributions. We are offering up, for people that engage with us and go the whole way, and you've been on this event today, then there's a 10% discount, which we'll communicate to you. We'd love to hear your feedback on future events. We're planning to run these on a monthly basis, on a technology of interest and on an area of medicine of interest. So if you see things here tonight, you want to know more, just reach out directly to us, and winbackmedical.com is our new UK website. So that's my little intro. Ignazi, why don't you pick up and we can get into the first part of the presentation.
Thanks for the introduction, Paul. Thanks to the confidence that you have in me. Let's go to speak today about pubalgia. Okay, and it's my pleasure to stay here with all of you guys, all of more than 40 colleagues that we're all together tonight to speak about this and the technology in the sport. So let's go with the presentation. So if we go to the international literature, we can find this fresh study that speak about all the terminology that we have high variation, because over the years many different names have been associated with this injury. Maybe the most common, like athletic pubalgia, growing pain, sports hernia, but also inguinal pain pubic syndrome, or hockey player syndrome, athletic hernia, and a lot of these. Okay, but what is really clear is that the growing pain is a common entity in athletes, that particularly those engaged in sports that require specific use or there's use, in that case, of lower abdominal muscles and the proximal muscle of the thigh. involving the hip. And what we know that it's clear that if we take the sphere of a watch, we can see that all these structures will be affected, like the superficial inguinal ring, the rectus abdominis, the pubic symphysis, the ductor longus, and the inguinal ligament. So if we go to the scientific data, we can find Gilmore that initially described like the Gilmore groins in the early 1990s with this specific description, okay? But more or less right now, after that, it's not clear, okay? But now what is accepted is that the pubalgia is a chronic groin lesion. That means that people, when comes us to the clinic or to the doctor, comes with some weeks or months of pain, sometimes with more or less pain, depending on the intensity that they are doing during the matches. But most of them that they have this pubalgia have an imbalance with the adductor muscles, in contrast with abdominal muscles at the pubis, that they have it really stiffness with an imbalance of the motor control, this control that increase the anterior pelvic tilt, that is going to increase also the tension in the insertion. So that leads to increase of the weakness of the posterior wall of the groin also. And of course, this imbalance leads to a deep groin pain. So if we go to the anatomy that is related with this injury, we can find, first of all, here all the pubic area with all the insertion of muscles. This is the typical MRA that we can find with this injury. And if we go more deeper, we can speak the anterolateral abdominal muscles that involve the external and internal oblique muscles, transversus abdominis and rectus abdominis, with this imbalance with the thigh adductors muscles that is going to be really stiff, the pectineus, gracilis, and of course the ductor longus brevis and magnus. Okay, so the most important, as I said in the slide before ago, is that the most important thing if we do a good manage of this injury is to maintain the stability in the sagittal plane of the anterior pelvis, okay? Because this imbalance with really stiff muscles can affect the correct function of this structure and finally develop with this groin pain or with a lot of different names, but we will describe it like pubalgia or like athletic pubalgia. So let's go to speak about the etiology and epidemiology. That, as I told you, there are a lot of terms that has been employed to explain these inguinal-related groin pains in athletes. Recently, also, the British Hernia Society in Manchester tried to develop the signs and different symptomatology. But what is clear is that all the sports that is going to involve repetitive, energetic, quicking, shooting, change of direction, which all of these are risk for causing pubalgia. Athletes with pubalgia are more predominantly male and generally under the age of 40 years because most of the people that play at these sports are around this age and are more male than females. But of course, the anatomical and biomechanical differences in the female pelvis structure, it seems that it's going to help to stabilize the pelvic region and decrease this risk to have pubalgia. But if we go to the causes of pubalgias, the most common is, as I told you, the muscular imbalance between the adductor muscles and the abdominal muscles, okay? But then we can find also in the scientific literature more things like rectus adductor syndrome. We can difference between an adductor and tensopathy, okay? Or also an pathology like the asymmetry of the symphysis of the pelvis. We can find most of the dance and sports hernia, okay? That it will be comes from the myopaneurotic parietal defect or an axial hernia of the abdominal wall that most of these cases finish with a chirurgical intervention. But also we can find these from this regional pathology, local regional pathology, that it could be related with nerve compression, like the obturator nerve or femoral cutaneous nerve, also the genital femoral nerve, or muscle disorders like the iliopsoas, hamstring, or bursitis in the iliopsoas, that it's going to be also in relation with this this balance between the ductors and the muscle group. Finally, also joint diseases that in the hip or in the sacroiliac joint could be also a cause of pubalgia. And finally, some genitourinary disorders. Also, we can find it in the literature that is gonna a cause of pubalgia. And of course, like in all other injuries, previous injuries in that zone increase the risk to have again a pubalgia. Okay. So after this, I want to recommend you this scientific study, a proposed algorithm for the management of athletes with athletic pubalgia that comes from different case series and try to do a protocol to have a really good return play process. But what we know in this symptomatology, this clinical signs, that most of the people that will come to our clinics with or in the team with this injury, they will feel a subjective complaint of deep groin lower abdominal pain. This pain is going to be exacerbated at these specific sports, okay, like kicking or doing the change of direction, sprinting. They will find the spot with pain. Most of the time, palpable tenderness over the pubic ramus at the insertion of the rector abdominis or in conjunction also with the tendon. Of course, a different range of motion, different angles, they will have pain with resistant hip adductions, okay? And also when they are doing the abdominal curl up, also they refer the pain in the pubis symphysis. So the treatment that we are doing right now is a combination with medical plus physio, but most of the times the treatment, the conservative treatment, it should be attempted like the first option, okay? But in line with the doctor, sometimes could be that a selective corticosteroid or PRP injection into the insertion could be a good solution to decrease the local inflammation and pain, and this can allow us to start to do some specific exercises or start to do some release tensions in the zone or some biologic treatment in that zone. But for example, in the case of some hernias, the surgical option could be the best solution. Okay, so if we are speaking that physio-conservative treatment is the first option, it is necessary to speak about physio time. It's our time. So first of all, it's necessary to speak that there are a really high difference between athletes when we are speaking about the return to play timings, how many months or weeks they need until they will come back to the sport, to the competition. And most of the times, because the situation that we have in the teams is that they play week by week. When we have an athlete with a pubalgia, most of the times we need to manage this pain, the functionality, and if we can keep the player in a pain around 2-3 in a scale of 10, most of the time they play for a lot of months with some pain, okay? So the first objectives that we will have or we need to have in mind is this anti-inflammatory medication in line with the sports doctor. They are the boss in this way. So in our case, if it's possible, going in line with the physical trainer also, no rest if it's possible. So we will try to manage the loads, to decrease the loads and try to don't stop the player 100%. For example, maybe he can do some running without high impact shocks, or he cannot kick, but maybe he can do some passes at low intensity. So we will need to try to keep as much as we can the activity, okay? Then we need to start to treat soft tissue with some mobilizations, trying to decrease this stiffness that we will find in the tissue and trying to become more compliant, okay, more viscoelastic, this tissue. And the TECAR is going to help us a lot in this area with the superficial and mid fascia treatment. We need to restore all the balance in the structure. So maybe it could be necessary some pelvis manipulations, okay, to recover this with the object to recover this correct balance. And of course, with growing pain, we need to recover all the range of motion in the joint without any pain. So, which is the paper of the TECAR treatment with this electrical transfer with these two modalities, the capacitive and the resistive. First of all, without a lot of temperature in increase, we can have this acceleration of the metabolism only to put the tissue under these frequencies between the 300 kilohertz until the 1,000 kilohertz or 1 megahertz. That we know that at these frequencies we can induce the exchange between the extracellular environment and the intracellular environment of the potassium ion, and then when we polarize this, then we will restore the correct function. Okay, so one function that in the body it's working at this velocity. Under the treatment, we start to do it really quick. So for other side, it's really important to have in mind the viscoelasticity of the tissues, because with the diathermic effect, we can increase the temperature and the viscoelastic properties of the tissues in a deep zone. So you can see, for example, these images where we can find with the elastography recording how the tissue pre-intervention and post-intervention can improve this viscoelasticity, these viscoelastic properties. Okay, and of course, for the synaptic interruption of the receptors, we can manage also the feeling of the pain. Okay, so if we start to speak with the WINBACK treatment, first of all, we need to prepare the tissue. Okay, warm up the tissue until the temperature that we want, and also when we start to work with capacity, as you can see in the left video of your screens, what we are doing is to decrease the impedance, the resistance of the tissue in the first centimeters of the tissue. So, for example, starting at 30% of the capacitive modality or at 50% of the deep set modality, that one is going to work at 500 kilohertz and the other one is going to work at 300 kilohertz, we can increase the temperature until the temperature that we want. We can warm up the tissue, and then with the resistive modality, after 5 to 6, 7 minutes, we can start to do some more deep treatment, doing with the saturation process from the inside to the outside of the tissue with the resistive. This is the most classical treatment, but it's going to be really useful for the first part of the treatment. After this, we need to test how it's going to work the tissue in the strain and stress specific test. So we will feel the tissue, how it's going to be more or less elastic, and the mobility of the tissue. So then we can go with this specific accessory, with this fascia accessory, trying to mobilize, to increase the mobility, the elasticity, to improve the quality of the tissue, of this surface tissue, with this accessory doing these movements in the same direction of the fascia. Okay. After this, we can put one side or the other one if we want to be more specific, or if we want to be more deep in the tissue, trying to restore this functional movement. And then after this, we will go, we will go with the deep fascial treatment or the soft tissue treatment also. In that case, after to prepare the tissue with the capacitive and the resistive, and to restore the surface of the tissue, I will put the bracelet with the resistive modality until around 40 to 60 of the percentage of the maximum intensity of the machine. And then I will try to go to the deep tissues and waiting to the different resistance that the tissue allow me to go deeper over the time. So what I feel in my fingers is that the tissue is going to relax, it's going to decrease their stiffness, and it's going to start to be more compliant, more viscoelastic, more elastic. Okay, so we can go all the spots, to the muscular spots that we can find this dysfunction, and also that it's really important to go between the different muscles, trying to go to the deep fascia and then to restore the good movement between the different muscles, okay? And in the case that we can find also, for example, after the ultrasound examination, that we have a degenerative process in one of the insertions, for example, the most common is in the adductor group, we can go with the air shock to increase the temperature at least from 5 to 8 minutes more than 40 degrees, because with this treatment we can increase the effect of or activate the neocollagenesis. That what we know for the scientific studies is that if we put one tissue at more than 40 degrees for 5 to 8 minutes, we can increase the synthesis of the collagen type 1, that is the most interesting for us in the correct evolution of the tendinopathies. And after this reactive phase that we have in the tendinopathies, try to go to the proliferative phase and not going to a degenerative phase. And this is really important then to manage it with the correct exercises, with the correct strength exercises, in one line for heavy strength resistant exercise, and in the other one for eccentric exercises. Okay, so as we said in the first objectives some slides ago, we need to restore the mobility, so we can introduce a protocol or a warm-up before the different trainings of active stretching exercises or mobility, that we can use the WINBACK also, integrating the mobility plus the benefits of the WINBACK. So for example, I will take the player, he will come with me to the table, I will prepare the tissue with the capacity from the deep capacity. If I feel that there are some tissues that are restricted, so I will try to restore the correct function without decreasing the tone of the muscle, okay? And then he will go to the gym with me or alone to do this protocol of different exercises about mobility, range of motion, active stretching exercises. As you can see here, for example, now for the hip, or if I go from stretching going to one side to the other one, thinking in the globality of the body, that we want to put all the back chain in tension and trying to restore all the points that we can find some tissues restricted, okay, that are affecting the correct function of the body. So here, for example, we are doing some active movements, trying to go more to one adductor and to the other one. I will put, okay. Then some stretching for the abdominals, stretching for the psoas grab. And also internal and external hip mobility without pain, of course, but trying to go to the maximum of the range of movement, of the capacity of the joint. Okay, here you have some examples. So, which is going to be the evolution of this program? So the main goal of the therapy is to correct this imbalance, take the correct balance between the hip and the pelvic muscles, starting with the stabilizers, and then improve the function of the dynamic muscles, okay? So we need to start with this reeducation of the different group, adductors plus the abdominals, and also coming from a good motor control, okay, with really good quality of this movement of the low back and the transversus of the abdominis. So it's not the same to do a squat, that do a squat with really good motor control, that the player has the control of this hip and this low back. And if the player has this correct control and have the good perception of his body, then when we will go to the field and start to put some change of direction, he can stabilize correctly with the dynamic changes of direction of the dynamic specific sports movement. So we need to start to improve all the core muscles, all the hip rotator muscles, the adductors and hamstrings, of course. So why I give you this infographic? Here, what I want to show you is this progression that this guy, this colleague, Adam Virgil, purposed us in the case that where we are thinking in strength training. So in all injuries, also this one, we will start with isometric contractions at low load, okay, without density. That means that, for example, 5 repetitions of 10 seconds. The first increase of load will be in more density of the exercise, improving from 10 seconds to until 30 seconds. Then after this, we will start with the concentric phase. That means that we will start to do some concentric exercises without pain, or maximum 2, 3 in a scale of 10 at low load and low velocity. As soon as we can, we will introduce the eccentric phase, but if we have the other 2 phases correctly, and then in parallel, we will improve the concentric exercises until the heavy strength resistance training, and the eccentric training also we will improve it, first of all in load and then in velocity. Okay, what is really important is to understand this, that first of all we will increase in loads and then in intensity. So that means that the evolution will be after to put power and to put the plyometrics, okay? And after this, okay, or in lane, we will put the impact. That means that the player will start to run, and then we will start to put some functional movements, some movements that we need to think in the specific sport movements that the player start to feel the injury or the pain, okay? So about this, some hip motor control and some specific exercises that we can do, okay? This is really important, that the player has a really good control of his hip, for example, doing a squat without any uncontrolled movement of his hip, okay? And doing some exercises that he can control all the time the position, okay, of the structure. Then, for example, here is the first phase where we can, okay, the first phase that we can do the isometrics with really good control of the transversus of the abdominis, improving the exercises, trying to put in a very slow progression some more exercises, and all of this we can integrate it with the benefits of the TECAR. So that means that we don't necessarily to stay 20 minutes in the table putting the resistive modality on the tissue. We can also warm up the tissue and then start to integrate all the active exercises, all the therapeutic exercises, plus the benefits of the TECAR, okay? And we can start to do some of these exercises, okay? And, or as you can see here also, include the chain, some exercises with similar biomechanical emphasis, okay? Here it's a really easy exercise, okay? But for example, for football, that they have more of them, they have pain in the pass or where they are kicking, this is really useful. Of course, if we go to the literature, this is really, really useful. I think that all of you know these exercises, the Copenhagen progression, that it's gonna work really good, and we can use it also in our progression of exercises, or also in a prevention program during the session, okay? And after this, we need to have more or less a screening test before the return to play. So this test will consist in a balance between the strength from the adductor group and the abduction group that we can, or the most important thing is to do it objective, okay, with a gauge of force, knowing how many newtons we can do in each movement. Of course, we will need to recover all full range of motion without pain. With the physical fitness trainer, of course, we need to don't have pain in the specific sport movements. Also, this good motor control of the lumbar and the hip of Kemp. And finally, we need to don't have pain in the adduction at different range of motion, 0 degrees, 45, and 90 degrees. And also, if we do it at the same time with abdominal curls ups, we need to don't have pain. Okay, so let me show you all the tests. With hip adduction, with abdominals, then going both sides, then contralateral sides, and then the other one also. And all of these tests, as you can see in the video, also the eccentric phase with really good control of the hip without pain, everything. So that's my presentation. I hope that it was interesting. I think I'm go more or less in the time that I have, around 30 minutes. So all yours.
Yeah, Ignazi, thank you. That was a really interesting presentation. I think it's a classic example of the progression of Ptechotherapy from being a passive, very successful treatment on the bed into something that's more dynamic and can be more widely used. So thank you for that, Ignazi. Now, if I could just throw it open to the group here and let's just maybe take 5 minutes. Questions to Ignazi on that particular presentation, or observations or experiences you may have had. So please, if you want to unmute and go for a question, Steve, I see you're unmuting. Just fire away your question, please.
First of all, Paul, if you allow me, I want to say that I'm really focused on the classical work that the physios can do in this presentation, okay? Because I don't introduce here all the exercises that we can do, for example, in the field, okay?
Sure.
With the ball, with all the agility drills and all of this, okay? But because the focus of the presentation also is to show how we can mix and integrate all the exercise that we can do in the gym with the TECAR therapy, for example, and all of this evolution that we said, okay?
Okay, that's cool. So around the group on the call, any particular questions or observations that you have in this area? Please just share away. We'll give it 5 minutes on this and then we'll get into the round table.
Ignazi, really interesting presentation, and thanks for putting that together, and really nice use of the TECAR, like Paul said, from the sort of the passive treatment to the active stuff. Just interested on your thoughts on the sort of neuromuscular control, and there's been some great work by the Sports Sanctuary group in Dublin with Enda King, looking at the sort of the cutting mechanics and groin injuries. Just be interested to hear your thoughts of that. Do you look at that sort of mechanics, that, you know, change of direction mechanics and frontal plane control, and is that the sort of neuromuscular control you're talking about, or how do you go about that aspect of the ring?
Yeah, well, what we're doing, or what we are trying to do is, first of all, to make an evaluation with surface AMG, and then with this we have the functional balance or the functional imbalance from different muscle group with different activations in specific exercises. Then with this, we most of the times try to work with different thresholds. For example, at 40% of the maximum voluntary contraction, or 50% with the inactivation of other muscle. For example, when we are doing extension on a hip, most of the times the quadratum lumborum is too much activated, and the gluteus is not working enough good. So then when we go to the gym, mixing with the WINBACK therapy, we try to focus with this, and this with touch control, or also with biofeedback, we try to fix this. Then when we are doing some biomechanical tests at high velocity, when we put all the signs to see it then in the 3D reconstruction, most of the time what we can see is that when the players are sprinting, the control of the hip, it's really poor. So they have some movements, and most of them, they fix it in an anterior pelvic position. And we also have we think that we have started to having a really good correlation. Also, looking what are doing all the scientific researches with hamstring injuries, with this imbalance of the pelvic hip. So it's what we are trying to do.
No. Thanks a lot.
Thanks for the question, Steve, and thanks for the answer, Ignazi. Any further questions or observations just on this whole area and how people might be approaching it? All right, great. Ignazi, thank you very much. So let's get into the questions for the panel there. So if you remember, what we were saying was, if you think of all the challenges everybody's been through in the pandemic, you know, I'd like to kind of ask each of the panel, you know, what they've seen, maybe kicking off with you, Steve, in terms of injury profile, type of injuries, maybe things that was surprising, lessons learned, if you like. You want to kick that off?
Yeah, no problem at all. Yeah, it'd be really interesting to hear what the guys from Game Changer, their experiences with the injuries they've seen this year. But I think the observations I was aware of and the early research was the stuff from Germany, which was saying that, you know, there was almost 3 times an increase in injury rates post-COVID, so in that immediate return after lockdown. And a lot of those injuries were in the players' first game. So I think injuries were almost threefold up to previous levels. I think the rates were sort of like 0.84 injuries per game. We've been previously, they were sort of 0.3 off the top of my head. So there was definitely that effect, and obviously that was from players having to do rehabilitation at home and, you know, not getting that exposure to high-speed running and not getting those gym exposures. Haven't seen the research coming through from the season, but early observations, and it'd be interesting to hear if there's any sort of pod physios on the call. We've seen that the injury rates are up. The one thing I would say is I think those who managed to survive and play regularly, I think once they were in, then the density of the fixtures was so once you made 3 or 4 games and got into that regular cycle of playing, that you had that huge chronic exposure to training and probably became quite robust. It was just the people who were unfortunate to not get that block of games in, who then had those subsequent injuries. So that was my initial observations. We're coming into the tournament now. We've got 3 or 4 players who are, you know, coming back from significant injuries, and I'm sure from what we're aware of other countries that they're in the same sort of position. And from my previous experience at tournaments, you know, 2 or 3 we've probably usually picked up, but, you know, it feels now it's maybe 4 or 5 this time who are carrying something and looking to rehabilitate in time for the tournament.
Great, Steve, thank you for that. Pete, maybe sort of pick up from the SGP experience, what you've seen.
Yeah, definitely. I think kind of we've been really busy, kind of from the amount of players who've been trying to come in, which again will probably highlight kind of more injuries, but again, backing up what Steve said then as well, kind of lack of access to facilities for a lot of players as well. Kind of from that rehab point of view, we've seen a lot of repeat injuries, again, off the back of, I think, lack of players' access to equipment to fully be able to rehabilitate the injuries they've got. I think myself and Dan went through our injury data for the last kind of 12 months, and kind of we've seen in last season, we saw about 7% of our injuries were hamstring injuries. And this year, it's about 20% of our injuries we've seen this year been hamstrings. Wow. So we've seen a huge increase in hamstrings, and they've often been repeat, like recurring injuries, and then very high level ones as well, often requiring surgery. So kind of that's probably been our biggest kind of notice of what's changed this season is definitely those hamstring injuries again, which off the back of lack of equipment to get strong, and then probably congested fixtures as well. Players not having as much time to train. So again, that high speed running probably not being completed enough, as well as obviously players not fully recovering in between fixtures as well. So that's kind of what we've noticed really.
That's interesting. Sorry.
Well, sorry, just jumping in there. I think that's really interesting observation. I think we were finding, talking to a lot of physios prior to internationals, is you have to be really brave to top up your high-speed running away from the games in the short periods you've got between games. So you've got a 3-day turnaround, and you might not be picking up the usual exposure of high-speed running you're getting in training. It's a brave medical and sort of sports medicine team who then sort of let the manager know that they need a top-up during training before they're going to go into another fixture. So I think we were definitely aware of that. If you don't pick it up just in the games and then trying to top up is really, really challenging. So another question, Pete, selfishly for me, was it'd be interested in any metrics that you saw or any interesting data from the lads. We picked up on some of our profiling where their sort of jump height on a sort of counter movement jump maintained following lockdown, but we did see generally across the board, and this is in the sort of youth football, that sort of eccentric mean power did seem to drop. So maybe suggesting that sort of the ability to decelerate, and maybe just because they didn't get exposure at home in lockdown and with just a treadmill, they weren't actually getting that exposure to the decels. So I don't know whether that had any consequence for the increase in injury rates, but that was something incidental that we picked up.
Yeah, we did notice with a lot of the players we were getting in, actually on eccentric, on the Nord and the isometric test we did, which is 90-90 bridge and 30-degree knee flexion, long lever bridge as well. We were often finding that the strength was actually quite good, kind of to the other side, but what we were finding was the rate of force development was massively down. Yeah, and that's kind of finding that the players were being able to, obviously had the strength there, but once they did start to go to that high-speed running and then sprinting, they probably just didn't have that rate of force development to be able to cope with those higher demands.
Yeah, that's interesting.
Did you find a relationship between the decrease of the performance of the jump with the contour movement jump with the central fatigue and the decrease of velocity? Do you have all the GPS data? Because, for example, in our case, also we have this. We have a decrease on the rate of force max development, do it in a force gauge, but then in a contact platform, we detect that most of the players, if we compare the data that we have in the pre-season of this year in comparison with the last year, they have really a decrease of explosive strength. And this is for you said, for all the months that they stay at home maintaining exercises without high intensity exercises. Do you have any data of this, Peter and Steve, about the explosive exercises and the decrease of the performance of this? I don't know if I explained enough.
No, I think you did. I think we haven't looked at all the metrics, but the key findings that we found of any interest was like you said, the concentric phase. They seem to have maintained that, and it was that eccentric mean power was the one that across the board the athletes hadn't been able to maintain. And I think similar to you, we saw that even the hamstring strength had been maintained, and we just do a simple isometric prone on the Nordic, and they had maintained that. But I totally agree with Pete. I don't think they were getting exposure to that high rate of force development or the stimulus they would pick up in training, and that probably fits in with the data of these injuries. It was a ridiculously short pre-season and straight back into the fixtures. I think one thing it has emphasised is maybe from a governing body and the EFL and Premier League group of how we can protect that pre-season maybe going forward for these athletes, because they need that 4 to 6 week period of training. And yeah, you may get away with it with a worldwide sort of pandemic, but moving forward we need to sort of protect these athletes, I think, and allow them to get that training block in before the season starts.
The last preseason also was really short in comparison with other years, at least in my team. And this year, for example, here in Spain, the competition was really more concentrated without the rest times that we had in other seasons also.
Yeah.
Right. Just Davey, interested in your comments here as well. Just what you saw in your experience.
I think what the lads have said. I think the lack of eccentric strength. I don't know whether that was the thing, but in the months of July and August, I ended up with 4 players needing knee surgery, 2 a lateral meniscectomy, a lateral meniscal repair, and 2 ACLs. And I mean, it was ridiculous. And it was just, they had maybe 6 weeks of training, but once we were into, and there was probably, let me think, 3 were in training and 1 was in a game. So that was 4 non-contact knee injuries over a sort of 6 to 8 week period. But going forward in the season, the soft tissue injuries, I didn't really, to be honest with you, the strength and conditioning and coach and the manager were quite good with sort of, building them up in a sensible way. So once we get past that period, and I think Steve had said that, once we get past that, we had about, over the season, 3 hamstring injuries, where you would normally maybe get, more than that. I know in the UEFA study they say you get about 7. We got 3, but interestingly, the 3 were all tendon involvement. Yeah. So, but other than, the 3 hamstring injuries, I never really seen a lot of muscle injuries. There wasn't a lot, and Steve said, I think once you get going, they were physically, once you get past that initial period, they coped with it. But the problem was right at the start, you end up with 4 guys with serious knee injuries. Yeah, and I mean, for us it was, and you think to yourself, how can you avoid that? And obviously, the lack of strength. I mean, all these guys were, as I say, they were running and training, but when you're just getting into, you're having maybe 4, 5, 6 months off in it or whatever it was, and then you're 5 months off and then you're getting into that. It was a recipe for disaster.
Interesting. Dan, it's always difficult. The next question you'll go first. But any further observations, Dan, on what's been said already?
One thing that came to my mind just following comments on that kind of robustness that the players have got when they're in and they're dealing with that fixture congestion. I think we were seeing a lot of not just high grade muscle injuries, but reoccurring high grade muscle injuries. And I think one thing that therapists have maybe found difficult is that transition from that rehab setting into that training setting, and players trying to bridge an even bigger gap going from training then into a congested match play, with a lot of clubs dealing with a lot of injuries, and therefore players that are being reintroduced into training may be going back into match play sooner than we'd ideally like. So yeah, we've certainly seen a lot of injuries that have been reoccurring issues for people.
Interesting. We've got one question here from Simon Edwards. So I'll just read it out. So it says, do you think that it was not actually sprinting over lockdown and then returning to sprinting too quickly that might have been the cause of the increase of hamstring injuries?
Yeah, I think that's been covered by a number on the panel, isn't it? Yeah, I think we totally agree that just that specificity and then not having a long enough period to ramp up and build into that is definitely what I think we've seen. And similar with those knee injuries that Dave was talking about, that you can't, again, this was this eccentric mean power that with the variable that we were looking at with the counter movement jumpers. You can do loads of stuff in a gym and you can do lots of deceleration stuff, but really specific to football. And if you're not getting that exposure and then you ask a team to have 2-3 weeks to prepare and then go into a dense fixture calendar, then yeah, like it's already been said, it's a recipe for disaster.
But I guess to close this kind of injury point, because I guess we covered some of the training sort of adaptations as well, but I mean, if there was one lesson that you took away from this personally, just, in this whole area of injury management and training, what would it be?
I'll go first again, sorry. But I think we talked about a mid-season break and a winter break, which we tried last year. For me, if you were going to try and protect anything, ring fence it would be that, protect that pre-season and try and limit clubs from going away on pre-season tours. Obviously that's where the finances are so important for clubs, but I think from a player care perspective, you need that block of training before a season starts.
Okay, thank you. Steve, Dan, comments? So the one big lesson you'd take away? I think we've got somebody who's got a lot of background noise, so I'll try and sort that out. But
so yeah, I think from speaking to a lot of players, I think just maybe where we've seen players from lower leagues that have struggled to access equipment, just kind of education on the sort of exercises that they can perform. So certain players that I spoke to during the lockdown was trying to emphasize where you're not able to lift heavy external loads, can you increase time under tension for eccentrics? Can you utilize isometric exercises through range to try and maintain that rate of force development that obviously we've noted that we've been lacking in our players. So just maybe being a little bit more creative with some of the exercises that we've been prescribing to make sure that we are kind of covering all bases.
Okay, cool. That's excellent. David, the one big takeaway for you over this period in terms of, what?
I just think you're trying to come back with not enough time. As Steve said, you can do all the running and the sort of stuff that you want away from football, but if you don't prepare properly and give yourself enough time to build up to that, that's then it's a you end up with problems. And I think we've seen that right through football with the amount of like knee injuries and stuff like that, non-contact stuff, and I think if we don't learn for that, I don't know where we go.
Okay, that's great. Thank you for those thoughts, guys. It was a lot of learning, and the one thing I wanted to we covered points 1 and 2, and I'm just going to ask, give me 2 seconds here. I'm walking and chewing gum. David, David Merlin, could we ask you to mute your phone there? We're getting a lot of background. So one area that just through the panel here would be, we talked about lockdown 1, big hit. Everybody's kind of wondering what's going on, then readapting and getting some normality into life professionally and personally. Lockdown 2 comes along, again, slight opening, and then boom, lockdown 3. In terms of the mental health side of things, I know none of us are psychologists, but I'm interested in, was that something that you as professionals with your teams and coaches and people around the teams had to kind of confront? And then how did you approach it? So maybe Dan, kick off with you this time.
Well, from kind of the perspective of some of the players that I continue to keep in contact with during the lockdown, I think just maintaining that consistency of communication, even if it is as we are now over Zoom meetings, was vital. Like players miss that team bonding, miss that being in that environment, and I think we'll all kind of testify as physios that they often tend to open up to us a little bit when they're on the treatment bed or in the physio room. So I think having that communication, even though it isn't as personal over your Zoom calls, I think it was still vital to maintain players' psychological health and certainly optimize from the players that I worked, optimize their rehab.
Great, thank you, Dan. Pete, from your side?
I think obviously some of the players we see aren't as lucky to have their own facilities really, and some of the clubs kind of share gyms with maybe a health centre or share gyms at a university or different college or something like that, and obviously they didn't have access to those facilities, so they were either kept away from the squad to be able to use somewhere or didn't have anywhere to use. And like I'm sure we've all tried to do throughout this time, tried to kind of change things around, use different equipment, use not the ideal for what we want. And obviously they really felt that they weren't progressing with their injuries quickly as they should have been, that they were going slower than they should, that obviously the risk of injury when they returned, they were worried about. So kind of that side of things from my point of view, those players I was talking about, that was a real concern for them, that obviously going forward for their career, if they are out injured for 12 weeks instead of 6, or they do re-injure and could be out for even longer, that was a lot of concerns that I heard from the players, was kind of just that lack of access to equipment really they felt was hindering how they were recovering really from their injuries.
Interesting. David, from your side, same question.
Yeah, I mean, I just totally agree. That's exactly where we were after the first lockdown. And then after, there was players that couldn't, even, we were seeing them, you couldn't see them, so you're trying to show them exercises, what to do over, FaceTime and all that kind of stuff. So that was difficult, and I think that held a couple of boys up. But, our manager was quite understanding, so they weren't. Once they come back, we just gave them time to, to get through and make sure they were okay. So I was fortunate enough from that point of view. But when it got to the second lockdown, the main thing was the young boys in the academy, because once our boys were back, there wasn't any problems for them for a lockdown. They were getting tested all the time, and it was the young lads who couldn't train. I felt sorry for, and they didn't know when they could come back. They're in Scotland, they can't train. They've not got any. So the coaches did Zoom calls with them, but they're training on their own. It was, and then they lost a year of their development. That was a big thing for these boys for the lockdown, the academy lads, and I think that's a shame. Some of the lads, and they might never recover from that.
Yeah, that's right. It's funny, it's a very good point. We kind of tend to think of the first team and the team, but you got a lot of people in clubs that are coming through and don't know what the heck is going on. So very, very good point. Ignazi, just from the Spanish perspective, that whole mental health, living in a bubble.
Well, you know that Andalusia is like a special part in Spain, that the people is really, really yes, distinta, really different. And here the lockdown, maybe the first one was really tough. The players comes after the first lockdown really, really tired. And our final part of the last season was really, really tough. I think that 3 or 4 more matches and maybe we lose the division and go to the second division. But after this, with Pellegrini now, with the new coach, I think that this coach is doing a really, really good job, because he's interacting with the players, with the team, with some videos, trying to put some games the weeks that we cannot go in the correct situation to the field, because there are one guy with COVID, and then all the group need to stay locked down for some days. And I think that they managed it really, really well. But the first lockdown was terrible, because the authorities also tell us, first of all, like, okay, this is going to be 2, 3, or 4 weeks maximum, and then we will go again to the competition. And the players were at home training really hard. And after this, 2 more weeks. And finally, we stopped early March. And until June, I think that we now restored the competition. So it was really, really long. And that's the situation we had here. The first lockdown was managed really bad. And the players come to the club again to train full burnout. And was the role,
Right, Ignazi, thank you. So listen, I'm conscious of everybody's time, so we're going to stick quite close to the time limit here. The final question, and then just maybe a wrap up. So, were there any technologies that, in this lockdown, or any approaches that kind of jumped off the, came to the forefront? Just from a personal business point of view, we saw a big ramp up in kind of blood flow restriction training, and people coming on to remote courses, and even players in Spain and Italy and the UK buying personal sets to try and reduce the kind of muscle loss that they might be getting. That's just a personal point. But going around the group, were there any technologies that particularly kind of shone through this period? And if so, just let me share who they were and what they were. David, you want to kick off on that one?
I just think that being able to speak to people like this, when I was a wee boy, this was like Star Trek. So, you know what I mean? So, I think it was a lifesaver for a lot of people that they could communicate. and so that, all this type of stuff, that was the big thing with technology for me.
Interesting. Dan, from your side?
I think, again, players that we were keeping in contact with during the lockdown, I think there were certain equipment like your blood flow restriction, like use of the Compex, that again were slightly different, that not only we know they have physiological benefits, but players were getting that they felt that they were doing something a little bit extra. They weren't just kind of doing a makeshift program. They were using something that they felt was really meaningful. So I think, it was a case of whatever we could utilize, we wanted to make sure we did so, even though, as Pete alluded to earlier, it may not be ideally what we want to use at that phase of their rehab. It may, just from a psychological point of view and from variation point of view in terms of their program, be actually adding extra benefit.
Okay, great, thank you for that. Steve, reflections there, anything that
a little bit similar but different, I suppose, to the comments that have already gone. The remote learning and the use of Zoom and the use of a screen, which we so for example, we were doing pre-training prep with the team, and we had them all spaced out 2 meters apart, due to COVID guidelines, and we had 26 senior England men's player all staring at a screen and following a virtual S&C coach. And the first time I've ever seen is every player did every part of the exercise and no one spoke to each other. They just stared at the screen. And if you flip that and put one of us at the front, there's no way in any time in my career that they'd all stare at me and follow exercise. So the one thing I think we've learned is you get an athlete a screen, or you send them to a yoga session, or you empower them with their phone. Whether that's just the generation they are, they'll stare at that screen and they'll go through the exercises. So we've flipped and left a lot of recovery strategies where, rather than a one-on-one, we'll send them the video and ask them to do it, or give them some options. And I don't think if it hadn't been for lockdown or hadn't been for COVID, we'd never even contemplated trying that. So even NHS-wise, I think that's the way forward. Let's empower these patients and see people remotely and guide them from a distance. We don't need all this passive one-to-one therapy. So that's probably the biggest change for us, and something we're definitely taking into the Euros of how we're going to work with the players.
Oh, it's interesting. I think everybody's business model has changed, whether it's what we do or what you do. And I think a perspective. There were times when our team would drive up to Manchester for a meeting that might not turn out to be a good meeting. So what we do now is we try and engage everybody in whatever format. We'll kind of talk to them in this kind of format, probably with a trainer. So let's just see, are you really interested in this? Is it something let's explain to you a little bit more of what it is, peer to peer. If it connects, then fine. We can send you the kit, you can try it, we can educate you online. So going forward, this is absolutely going to be part of our business model. And I think all the physio clinics are the same. It's just going to be a pathway that's used to triage, patients through the rehab. So, Ignazi, don't want to sort of lose you on this one as well. So, from your side, just final reflections on what came through for you. So, great points there on communication, Zoom, education. Probably players learning more about how to train and what they're doing in group sessions on Zoom. From the Spanish side, any reflections?
Yes. We try to use the Zoom with the players, for example, during the lockdown, and also all of these. We try to implement some new strategies using technology and all the things that you said, guys. But for example, I think that finally depends more about the attitude of each player, at least, because you can have all the technology, you can have all the instruments, you can have low flow restriction, you can have TECAR, you can have trying to communicate with new technologies, but finally it's a own decision of each player. If in front of the complicated situations, if they want to become the best players as they can, or if they want to be mid-range.
They'll find a way. The champions will always find a way. So listen, great. I really appreciate all the inputs and discussion. So let's kind of throw it open to, in the kind of 5 minutes we've got left before we wrap up. Any particular points that people in the audience, we still have quite a few people on the call here that want to ask the panel. Please just use this opportunity. Trying to see if. Great. Well, listen, guys. Firstly, my thanks to Ignazi for preparation on his presentation. It's really, really interesting, and I hope everybody enjoyed it. And to Davey, to Steve, to Pete, to Dan, people who participated this evening, I hope you found this of value. And wishing all the sort of home nations guys, England, Scotland, great success. Don't get injured. Let's get to the games and get through, and one of us win it. And wish you a great evening, and thank you for your participation this evening.